will be on in a few. So, good evening, everyone. Welcome to Medical Mondays with Dr. O. I am Toyin Okpesomi, a family practitioner, HIV specialist, and I treat addictions in Maryland, or let me say across Maryland. I enjoy learning and teaching, and we're going to continue doing that today as we do every week. Tonight, we have Dr. Gina Dapul-Hidalgo. She's an allergist in Maryland, and she would introduce herself better to tell you about her practice. She'll be talking to us tonight about allergic rhinitis, which is something that plagues a lot of people during this season, the spring season. If you live in Maryland, they say if you live in Maryland long enough, you will develop allergic rhinitis, but it's true for everywhere, no matter where you are in the world. So without much ado, Dr. Dapul-Hidalgo, the floor is yours. And welcome to Medical Mondays with Dr. O.
Thank you, Dr. O. Such a pleasure. Thank you so much for inviting me to be on your platform and to speak to your audience this evening. So as Dr. O said, my name is Dr. Gina Dapul-Hidalgo, and I actually go by Dr. Dapul or Dr. Gina since it's a little shorter to call me that. So during clinic, that's how patients refer to me. But today, yes, I am a board certified allergist immunologist located in Montgomery County. Right now, my practice is in Gaithersburg, Maryland, and we'll be moving in a couple months down to Rockville, Maryland, so still in the same area. And I am the CEO and founder of a practice family center for allergy and asthma. And so we see both infants and adults, so anywhere from kids to adults, to help them with all of their allergic conditions and asthma. So yes, we can be reached on our website, which is here, www.dapulallergy.com. And today I have the pleasure of speaking with you about, as Dr. O mentioned, allergic rhinitis. And this is a very common condition that many people are suffering from as we speak, especially as our pollen counts go up. And we'll talk more about it. And hopefully you'll be able to walk away with a lot of tips that you can help yourself, your family, towards the end of the talk, so that that can help you at least do some things that might be able to provide some relief during these next couple of months. Okay, so here we go. All right, so what we will be speaking about is the definition of allergic rhinitis, the burden that it causes, risk factors for this condition, the pathophysiology, and specifically, we'll get into a lot more of the seasonal allergic rhinitis component, how we evaluate patients who come see us for this, and then treatment. So again, we'll cover these in more detail, and hopefully we'll walk away with some helpful information. So what is allergic rhinitis? So this is where we have inflammation of the nasal passages that's caused by the body's reaction to airborne allergens. So to take a step back, how I describe allergies is that your body is actually overreacting to a harmless substance. Right? So we're not supposed to be allergic to pollen, cats, dogs, dust mites, foods, drugs. But if we are, it means that our immune system is overreacting to something that's typically harmless for most people out there. And so this is one condition that is allergic in nature, and again, overreacting to some type of allergen. So the signs and symptoms that we see here in allergic rhinitis are things like congestion, rhinorrhea, which is a runny nose, sneezing, itching, postnasal drip, cough, irritability, and fatigue. And we break the classification down depending on if it's seasonal, so again, during certain times of the year, or perennial, meaning it can be all year round. So the burden of this condition is that it is so common, as we had mentioned earlier. This affects about 10 to 30% of adults and up to 40% of children worldwide. And the worldwide prevalence is increasing. And so keeping in mind prevalence, what that is, it's the proportion of the population with a certain characteristic or condition at a certain period in time. So again, this is increasing throughout the world. Interestingly, I saw a study that was based out of Nigeria that was a survey, and the prevalence there, this was published in 2019, is 22.8% of having allergic rhinitis. So this condition impacts quality of life. So for those who have it, or for those who have family members who suffer from this, you'll see that this often interferes with sleep and can contribute to poor academic and work performance. So this accounts for at least 2.5% of all clinical visits, 2 million lost school days, and 6 million lost work days. So again, from all of these symptoms and how it affects us, it's taking away kids from school, from people from work. And so this really does impact your quality of life. There's a high cost to individuals and our society. So about more than 7 billion direct costs and more than 4 billion indirect costs in the United States per year. What are the risk factors for developing allergic rhinitis? So the main risk factor is actually having a family history of atopic disease. So atopic disease, or atopy, is the genetic predisposition to developing allergic diseases. So some of the ones that come with this can be things that you may have heard of, eczema, as well as asthma. And then again, we have allergic rhinitis. So this is kind of a big umbrella of what we call atopic disease. Other risk factors can be being of the male sex, being born during pollen season, early use of antibiotics, maternal smoking in the first year of life, exposure to indoor allergens such as dust mites, having what we call a serum immunoglobulin E, or IgE level of more than 100 international units per ml before the age of 6, and then having the presence of allergen-specific IgE. So again, these are the risk factors, number one being family history. So what is the pathophysiology of this, allergic inflammation? And so what happens here is that the symptoms of allergic rhinitis are caused by the mucosal reaction to chemicals released by tissue mast cells upon degranulation. And this is an IgE-dependent mechanism. So
bẹ́ẹ̀ni ẹ jẹ́ wò ó ti wà ókè báyìí bọ̀ ó kú bí tíntín ní kan ẹ jẹ́ sáré ṣe fún yín ẹ jẹ́ sáré wò kẹ́ ẹ bá mi sọ kò ṣó ẹni ẹ̀rọ.
So what we have here,
tí ò bá ti ṣe.
Yes, what we have here is this IgE-dependent mechanism. So this again is the whole, crust of how allergies work. And so what we have is the early phase, late phase, and if it keeps going on, we have the chronic phase. So the big player here is called the mast cell. So this is the little purple cell here. Hopefully you're able to see my mouse as I point to it. But the early phase, so this is typically what happens and occurs within a few minutes of being exposed to the allergen. And it can last for 1 to 2 hours after exposure. So here I'm going to explain this diagram. So the little red dot is the allergen. And there's, again, the mast cell, which is the purple cell. Once the allergen is inhaled, it binds to this Y-shaped molecule, which is called the IgE. And once it does this, the IgEs are actually touching each other, and it causes what we say cross-linking. So that red allergen binds to its IgE, cross-links on the mast cell, and then it causes a whole host of release of chemicals and mediators. So again, this is the beginning of these allergic reactions. And in our context, we're talking about it in allergic rhinitis, but this is the same mechanism if we're talking about food allergies or allergic asthma. So what happens again is that these mediators, especially histamine, is being released, and this is what's causing the symptoms. So what we have on this right side are angiogenesis, vasodilation. We have increased vascular permeability. And then these are pictures of nerves that stimulate nerve roots, and then it can cause some sneezing in terms of motor reflexes. So all of these, the angiogenesis, vasodilation, increased vascular permeability, and the nerve endings cause the symptoms of sneezing, congestion, and rhinorrhea. The second part of the early phase is that these cytokines and chemokines are then released from the mast cell, and then I like to explain that it causes its friends to join the party. So it recruits other inflammatory cells to come to the site of inflammation. So this is where we have the late phase happening. And this typically occurs 5 hours after allergen exposure and can last up to 24 hours. So again, those cytokines and chemokines are recruiting eosinophils, basophils, neutrophils, lymphocytes, Th2 cells, and then this is what causes the prolongation of the allergic inflammation. The last phase is the chronic phase. So this is what the allergic inflammation can evolve into if the allergic reaction fails to resolve on its own or within time. So this is what happens when we have continuous exposure to the allergen, and or if it's a very severe disease or severe atopy. So comorbidities associated with allergic rhinitis. So again, with the allergic rhinitis, we do tend to see other atopic conditions, as we mentioned earlier, and that's asthma, atopic dermatitis or eczema, chronic rhinosinusitis, sleep apnea, and gastroesophageal reflux disease. So these are some conditions that our patients will also have because they have allergic rhinitis. So here we go, seasonal allergic rhinitis. So symptoms are experienced at certain times of the year. This is usually caused by pollen from trees, grass, weeds, as well as mold spores. And probably many of us are not familiar with pollen. So what is that? So these are grains or tiny seeds of flowering plants, and they are crucial in the role of reproduction. So the thing about the trees, grass, and weed pollen is that they're very small, they're light, and they're dry, which is why they can be easily spread in the wind, and they become airborne. So because they're airborne, they can travel long distances, and they can also be inhaled by us humans, causing the symptoms. So depending on the geographic area, pollination periods for certain types of plants are well known, and they are predictable and reproducible from year to year. So how many people are affected by seasonal allergic rhinitis? So in 2021, approximately 81 million people in the United States were diagnosed with seasonal allergic rhinitis. So that's about 26% of adults, 67 million people, and then 19% of children, which is 14 million children. So again, as we were talking about earlier, very, very common and affects many people and has the potential to really affect our patients. So here are the peak pollen seasons in the United States. So on the left-hand side are the different geographic regions. On the top are the different months. So in general, our tree pollen are what come out in the spring. Our grasses, the grass pollen, peak in end of spring into summer. And then our weed pollen comes out typically end of summer into fall. So again, depending where you are in the US, you might say, okay, it's always spring for me. Then it's likely tree pollen. But if it's more fall, end of summer, then it can be weed pollen. But it can be a combination of both because we do see them out at the same time. So the pollen count. This is how much pollen is in the air. And there's different devices that are used to capture the pollen, and then the sample pollens are identified and counted. So here's a picture of one device in particular, and this is near and dear to my heart because I actually did the pollen counting when I was in my allergy immunology fellowship in Brooklyn. And what we would do if it was our week to pollen count, we'd go up to the roof, pick up these rods, and then count them and report them to the local news. So here, as we can see in this picture on the left, there are these little rods that come up, and they do come up intermittently from being in the metal piece. So then they spin. So if you look in the second picture here, we're seeing it spin, and that's what's collecting the pollen. What we then do is take those rods, stick them onto these special slides, stain them, and then we are hand counting the number of pollen that is seen per high power field. And so based on this, as well as some calculations that are done, that's what is reported for your local pollen count. So as I was stating, local and regional pollen and mold counts are often broadcast along with your local weather, and it's reported as low, moderate, high, or very high. And if you can imagine that it's collecting the data from the day before, it actually reflects the previous 24 hours. So when it's reported, it's the 24 hours beforehand and not the actual day that you're receiving the pollen count. Something to keep in mind. So here's an example of what we've seen here in the Washington, D.C. area in terms of our pollen. So we have on the x-axis, the months, the y-axis, the grains per cubic meter. And this is data from 2017 to 2023 that was published in the Washington Post just last month. So the average, we see this blue bar right here. We look on the back, the blue teal, it peaks in April and May. But interestingly, what we have seen since 2017 is a very interesting pattern where, for example, in 2023, which is the red bar, we have had a peak in February, right? So this is super early, and then another peak in April. And so there's many, reasons for this. We're seeing that the winters are now much shorter, if we even have a winter, that the pollen are coming out earlier and lasting much longer. So this is why patients or people, if you're experiencing this yourself, may see a little bit of some relief, but then it potentially can come back. So this again is what's happened in the Washington, D.C. area in the past couple years. So here are some, interesting pictures so that you have a sense of what's going on with these trees and grasses and weeds. So these are a picture of some birch trees. And on the right-hand side up here, these are actually this little cylindrical flower that's hanging down are called catkins. And again, this is all in terms of reproduction and fertilization of the trees, grasses, and weeds. But for these particular trees, these catkins hold the pollen. And then this is what is dispersed in the air and is pollinated by the wind. And again, these are catkins for the birch tree pollen. I love seeing these pictures because these are, what the pollen look like under the microscope. So again, this is a picture of a birch tree pollen at about 400 magnification. So this I thought was interesting. It's actually a video, but what I was able to do was take a picture of it from the beginning to the end. And if you see here on the left-hand side, we just see a tree. This was actually taken by a wife after her husband was in this digger. And he actually tapped on the tree, and this is what pollen came out. So you see this huge cloud of pollen. And again, this is visible to the naked eye, which is why I tell patients that, these are usually microscopic. So when we can see yellow and green on our cars, that means it's visible and that the pollen count is through the roof. So again, great visual to understand that this is what affects us and our patients. Here is a maple tree. And this, again, on the right-hand side is a picture of the maple pollen under the microscope. For some, depending on the angle, it can actually look like a little beach ball. And then here's Timothy grass, what they look like on the left, and this is the pollen on the right. And ragweed, which I'm sure many people have had experience with. So ragweed is a weed that grows throughout the United States, especially in the eastern and midwestern states. And each plant lives for only one season. So right, it only lives for one season, but one plant can produce up to 1 billion pollen grains. So again, this is something that comes out typically end of summer into fall. And if we have symptoms, it's because one plant is releasing 1 billion pollen grains. So again, this is ragweed, and this is what it looks like under the microscope. So what happens when you come see a board-certified allergist for evaluation of your allergies? So we ask ourselves 3 questions. Are your symptoms associated with an IgE-mediated reaction? So the symptoms we talked about before: sneezing, itching, runny nose, congestion. Number 2 is antigen-specific IgE detectable. And so how do we find this out? Well, if you go to an allergist's office, we do what's called skin prick testing or intradermal testing. And I'll discuss what this is, but it's a histamine-based reaction. And that's why you might be asked to hold antihistamines 5 to 7 days before you come to our office. Because if you take these medicines, it does interfere with the test. So that's why if you're able to hold it, then it gives us a good test. So here's a picture of somebody's skin test on their forearm. We typically either do it on your forearm or on your back because these are sensitive areas. And what we are doing is scratching on liquid, so purified extract from different allergens. So right now, from tree pollen, grass pollen, weed pollen, it can be even year-round allergens like pets, dust mite, horse. So what we do is that we scratch this on the skin, and then we're waiting for an allergic reaction, which is very similar to the pathophysiology that I had discussed earlier. So if your body had made that allergic antibody, those Y-shaped molecules, then I'm going to do this with my hands so we can remember again. This is an IgE antibody. And not many people make this. Again, it's patients who see me that make this because of the environment, because of genetics. And now it's waiting for its partner. And then when we scratch on the liquid, let's say tree pollen, it'll say, there's my partner. It will release chemicals. And then in 15, 20 minutes, we have a positive reaction. And that's the same mechanism of why we have symptoms, because again, your body made this allergic antibody. You breathe it in during pollen season. It releases chemicals in 15, 20 minutes, like histamine. And that's when we have all the symptoms. So here, for example, we have a wheal and a flare positive reaction. And so the allergist will either measure the bump, which is what we call the wheal, and the flare, which is the redness. So there's different techniques on doing this. So this can tell us that you have made these allergic antibodies to the allergens that we're testing, or if it's negative, then it tells us you did not make those allergic antibodies. If you're unable to do skin testing in the office, then there is the option for in vitro testing or blood work, such as immunocap. So we tend to not do that as often when possible. Skin testing is actually more cost effective. And the thing about blood tests is that you have to go get some blood drawn, and it does take a few days to get the results back. But if you get skin testing done and you're able to hold your antihistamines, we'll have our answer in 15 to 20 minutes while you're in the office. So the last part of the evaluation is, does the allergen exposure match with the patient's symptoms? So again, the presence of the allergen or antigen in the environment, and is there that pattern of either seasonal or perennial symptoms? So now that we have gotten a really good history of what's happening with you and the patient, we've done some testing after doing a physical exam. Now, the important part is talking about how do we treat this. So there are 3 components to this. And the first one, which is very, very important, is the allergen avoidance. So let's say you come in, we find out that you're allergic to certain pollen. These are the recommendations that we would talk about so that you can decrease your exposure to the pollen allergens. So what we recommend is to start taking your allergy treatments before pollen season begins. This makes it more effective because it's harder to control the symptoms once you actually have them full blown, but it's easier to prevent them before they even start because of that histamine pathway. So usually in the past, we would tell patients, start taking it around Valentine's Day, February 14th, but now it's actually being pushed earlier because as we spoke and you saw on the chart, we're seeing the pollen counts start in early February. Another recommendation would be to limit your outdoor activities when pollen counts are high. So that's why it's important to monitor the counts. Pollen is actually highest in the morning up until midday, and it's lowest early morning, as well as late afternoon and evening. So if you're going for a walk, do it either early in the morning or late afternoon and evening. This is very common sense, but sometimes, we say, oh, we like fresh air, but really we want to keep our windows closed during pollen season because those microscopic grains can come through the window and then settle in your furniture, in your carpet, and that can continue to give you some symptoms. We recommend to use air conditioning at home and in your car, and then to use air cleaners or HEPA, high efficiency particulate air filtration, to reduce the inborn allergens. This can include indoor airborne allergens. This can include the pollen that end up coming in when we open our doors, our windows, or if our pets come in from outside, they can bring the pollen in too. So that's why it's important to have a HEPA filter inside the house. Important to wear sunglasses and cover your hair when going outside so that the pollen doesn't go into your eyes or settle into your hair. Shower daily before going to bed. So especially if you've been outside for a while, come home, wash this all off so that we're not sleeping with the pollen overnight. Limit close contact with pets that spend a lot of time outdoors. So again, if we come from outside with our pets, we kind of want to wipe it down and try to decrease the pollen that's being brought in the house. Change and wash clothes during outdoor activities. So if kids are playing sports or we're going on nice long walks, you want to make sure we come home and change our clothes without dragging it all over the house, because again, that will bring the pollen in everywhere. We recommend to dry your clothes in a clothes dryer and not to hang them outside on an outdoor line. So importantly, we want to measure the pollen counts and the forecasts, because this will give us an idea of, when we should be outside, if today might not be a good day to be out there because it's a very high count. And one of the ways is this website, which we'll talk about next. Okay, so we have the American Academy of Allergy, Asthma, and Immunology National Allergy Bureau. So the website is pollen.AAAAI, that's 4 A's and an I.org. So once you go on this website, you can actually click on the part of the country that you're in, and then there are pollen counters. So as I said, I had done it for the Brooklyn pollen counting station when I was in training. And so when you click on this, whatever red dot is closest to you, it will bring you the local pollen counts. You can subscribe for emails and get updates. So this is volunteer from different allergists who are part of the Quad AI, and that's how we're able to present the information to the general public. Okay, so again, second component of treatment is pharmacotherapy. So these are medicines. Well, which medicines can be helpful? Here are the class of medicines that you might find useful. Many of them are now over the counter, although previously they did used to be prescription, but now many of them every year are going OTC. So intranasal corticosteroids, here we have fluticasone, mometasone, triamcinolone. We have intranasal antihistamines, so not steroids, but antihistamines for the nose. So things like azolastine or olopatadine. If you are using nasal sprays, the important thing is how to spray it in the nose. So you don't want to aim it up, because it'll just go up your nose and down the back of the throat. But what's swollen and makes the mucus are on the sides. So you want to tilt these nose sprays out to the ears. And I do this with my patients every day, multiple times a day, so that we aim it that way towards the ears. So again, that's such a small technique, but when you make the right change, it can be much more effective. So next is a big class, which I'm sure many people have tried, are oral antihistamines. So we have those like cetirizine, loratadine, fexofenadine, levocetirizine. And these are the mainstay because, again, we saw that the mechanism is histamine being released, and that's why antihistamines will be helpful for this. We also have a combination of oral antihistamines and decongestants, but we really don't recommend the decongestants because of its side effects. So if you're going to use it, you do have to show your pharmacist your ID, it's behind the counter. But in general, I typically don't even recommend it. And I would rather do a prescription antihistamine in order to have patients not take a decongestant. Other options are medications which are oral. So we have what are called oral leukotriene antagonists, and the two main ones are montelukast and zafirlukast. So this is approved for kids 2 years old and up. But in 2020, the US FDA, Food and Drug Administration, actually placed a black box warning on this because many patients were having the side effects of neuropsychiatric changes. So everything from agitation, irritability, depression, suicidal ideation. So typically, I prefer to only prescribe this for patients who may have not only allergic rhinitis, but also asthma, because it's approved for both upper and lower airway. Other options are nasal lavage. So these are, nasal sinus rinses, which are salt water. So it's not really medical therapy, but it can help to wash away all the allergens that are sitting in your nasal passages. So that's, again, just salt water. And then less commonly used therapies are other nose sprays like cromolyn nasal spray, which is a mast cell stabilizer, and ipratropium bromide nasal spray, which is an anticholinergic. So how we use these medications really depends on what works. So what works for one patient or one person may not work for another. So it can be a combination of a tablet plus a nose spray, or just the tablet and only adding the nose spray when symptoms are really severe. So really it's just dependent on what is effective for that particular person. Finally, the last thing to talk about in terms of treatment is a very well-known therapy called allergen-specific immunotherapy, also called AIT. So what this consists of is repeated administration of increasing amounts of allergens to provide protection against IgE-mediated disease. So we begin with very small doses of the allergen, and we gradually increase to higher doses until we reach what's called a maintenance dose. So the exact mechanisms for this are not fully identified, but we believe that this results in immunologic changes such as regulatory T lymphocytes, a shift from type 2 to type 1 immunity, and eventual reduction of the specific IgE levels, which again are a big cause of these symptoms. So what happens when you're on this therapy? You'll have fewer symptoms and also having long-lasting tolerance to the allergens. So AIT is an effective therapy for adults and children with allergic rhinitis, allergic rhinoconjunctivitis, meaning those who are affected with the eyes and the nose, allergic asthma, and it's also used for those with very severe bee sting allergies, what we call Hymenoptera venom allergy. So the commonly used methods that we use in an allergist's office are subcutaneous injections. So those are injections that go in the fat part of the arm, which is why if you've heard of the term allergy shots, this is it. And this has actually been used for over a century, when in 1911, doctors were purifying grass, doing studies on patients, and then finding that it was helpful for relieving their symptoms. So again, over 100 years, and it's more refined now, but it's still something that really helps patients, especially if the medications are no longer effective for controlling symptoms. There is a risk of anaphylaxis, which is a severe allergic reaction, which is why this particular therapy is something that's done in an allergist's office, somebody who knows how to treat anaphylaxis if you were to have a reaction to the allergy shot. Again, rare, but it is one of the risks that we talk about prior to starting therapy. There's also the option for sublingual tablets, and there are some FDA-approved ones for grass, ragweed, as well as the perennial allergen dust mite. So that may be an option for specific patients. So when do you get referred to an allergist immunologist? So when you come see me is for individuals whom the diagnosis is in question. So really what we spend a lot of time in is getting your history. So we talk, we ask a lot of questions and try to figure out what are the symptoms you're presenting with related to allergic rhinitis. If you're an individual with specific significant environmental exposures, so typically an example of this would be if you have, your cats and your dogs, and we wish to keep them and not part with them. Many patients, will start these allergy shots in order to have symptom relief, but keep their pets. Individuals who fail medical management. So as I said, if the nose sprays, the over-the-counter tablets, and even eye drops are not enough to control your symptoms, then that's a reason to come see us. if you have comorbid conditions such as asthma or atopic dermatitis or eczema, these are reasons to come to us as well, because we take care of all of these conditions, since they all go together, as we talked about, because of the atopy. And another reason to come see us is if you're interested in these allergy shots. Again, allergen-specific immunotherapy. So in summary, allergic rhinitis is the inflammation of the nasal passages caused by reactions to these airborne allergens. And specifically, seasonal allergic rhinitis is what affects people during certain times of the year and are caused by the trees, grass, and weed pollen, as well as mold spores. And the management options are allergen avoidance when possible.
Do you hear me?
Pharmacotherapy, and allergen-specific immunotherapy.
Mm.
So hopefully we found this helpful, and I'm happy. Thank you so much for your attention, and I'm happy to take questions and discuss how this may be affecting you and your family members.
Thank you so much. That was fabulous. And thank you for bringing up that research in Nigeria. So, because growing up, I know that my mom and my sister had bad allergies, and my mom did till, she went home to the Lord, and my sister still does. So when you showed that, I'm like, But in Nigeria, when most people have allergic rhinitis or allergy symptoms, they diagnose them with malaria. I see this all the time. And when I take history, ask specific questions because malaria medications are not resolving their symptoms, I find out that, it is allergic rhinitis they have. So this is very, very important. So if you put down this slide, it's going to help me to be able to see people who want to ask questions.
Oh, okay.
You can raise your hands to ask questions, or we can, you can put it in the chat box. I have some questions in the chat box already, and I'm going to read them out to you.
Okay, wonderful.
First one from Dr. Ajagbe. And hi, Haman from London.
Wow.
Nice to have you. So Dr. Ajagbe asked, do you see higher incidences of mouth breathing during this period? No, I don't think that was his first question. Yeah, it was. Okay. The first question was, would the use of face mask be recommended to people who are susceptible to topical allergens?
Yes, so that's so interesting, especially given what we have experienced the past, 3 to 4 years, where in the peak of the pandemic, patients were wearing masks because those were what was recommended. And we actually saw a decrease of allergy symptoms because you are decreasing your exposure to these environmental allergens that you are breathing in. So I don't know if studies have been done with that, but anecdotally, the patients I saw, there was a little dip because we weren't around people, we were wearing masks. And so again, these microscopic pollen are what enter our nasal passages, are what cause the mast cells to be released. So yes, wearing a mask does help. And even actually before the pandemic, we were recommending to patients, especially if you are allergic to grass pollen and you're mowing the lawn, or you take a walk and your neighbors have their freshly cut lawn, that pollen is in the air. And so people will say, oh, when I go and mow the lawn, I have to wear a mask. So yes, very, very common that is a way to a physical barrier of not being exposed to these outdoor seasonal allergens. Great question.
Yeah, great question. That is true. We used to recommend masks, and but now I tell my patients, look, it's in season, it's in vogue because of COVID. Nobody will know why you're wearing it. Before, people look at people wearing masks and think they're weird, but
yes,
that story has changed. Dr. Jagbe, you have your hand raised. You can ask your questions, sir. Kindly unmute. Please unmute. Thank you.
Yeah, excellent presentation. Thank you so much.
Oh, thank you, Dr. Jack.
I have two things to address. The first one is following up on the face mask. I was one of the few people that I know that had very severe allergies in the past. And incidentally, I used to think I was so terribly allergic to dogwood plants, pollen. Oh my God. You know, I felt like anywhere I saw dogwood, they should just mow them down, cut them down. But incidentally, until I met Dr. O, Dr. O said this is not acceptable. When she first saw me, I was in distress, not just nasal passage, but I'm talking about status asthmaticus, severe asthma. My shoulders were always raised. My eyes were always red. People thought I was angry all the time, but they had no idea that I was struggling to breathe. But anyhow, it came out that when I saw Dr. O, and she said, this is not acceptable. That if I gave her permission, that we would take care of this thing aggressively. And she said, okay, if you give me permission, we'll take care of this. I said, well, I've tried everything. It's all right. I have nothing to lose. If she was able to deliver what she said, then I would be the better for it. So I submitted to consult. And I'm sorry, I don't want to take too much of the time, but I think it might be helpful to some people. So the first appointment I went to her office, my status asthmaticus was challenged to the extreme just by air freshener.
Yes.
So I went into the office, they had just sprayed air freshener. I did not know, the place smells beautiful, but I went into bronchospasm.
Yes.
It was good that she had the medication and the nebulizer in the office. Otherwise, I would be in the emergency room with 911 blaring the siren all the way down. But, so I was put on nebulizer for 30 minutes. My airway was opened up, then we could talk. But before then, she hasn't seen me before I went into bronchospasm. Now, to make the thing more interesting, see, I used to think I was very allergic to environmental allergens. When we did the blood work with specific antigens, she opened her mouth. She couldn't believe the result. Believe it or not, I was not even allergic to any environmental allergen.
Yes.
Except cockroaches. But the dogwood didn't even show. I mean, everywhere I saw dogwood, I was trimming it down in my yard. I was cutting. Every new one that showed up, I was cutting down. But, I was so shocked. Now, it turned out that my own experience may be unique to me, but I think it might just be the tip of the iceberg for many people. We found out that it is not even environmental allergens. It was food allergens that I was dealing with. The list of foods I cannot touch. I mean, when you talk about allergen avoidance, that was my approach immediately. As soon as she gave me the list, because she told me, no, you cannot I won't talk to you on the phone. You have to come in. Because when she saw the list, she said, oh my God, I can't even tell this person on the phone what is going on with him. So I said, please come in, schedule an appointment to come in, let's talk.
And talk.
When I got in there, he said, you need to sit down. I said, what's the deal? I mean, am I dying? Then she said, no, I mean, I just can't believe that somebody has such allergy as yours. And then by the time we went through the list, she looked at me and said, so what are you going to be eating? So I said, don't worry, just give me the list, because now I feel better. So I don't really want to go back into that vicious cycle.
Mhm.
So I took the list and I had to go and look for alternative menu. And I made the list and sent it to her and said, look, I came up with this list of alternatives, and said, oh, now I can breathe. Now she says she was relieved because now she wasn't worried that I won't be able to eat anything. And till today, it's been a while now, many years. I'm still doing the allergen avoidance, complete avoidance. I don't even crave them. I don't miss them because I know how well I feel right now. I feel so good. I'm not on any medication for respiratory asthma. I'm
Wow.
not on any maintenance, anything. Though nothing. And I haven't had any irritation in my lungs for the past 5 years.
That's
So now I can go under the tree with the pollen, and I do not even have
have the
anything.
symptoms.
So what I'm trying to
Yes.
say is this: a whole lot of people might be having the so-called seasonal allergy that actually it's an acute exacerbation of what they already have. So it's not really the pollen itself that is the original cause, but is just the trigger to what is already in them. So it
Yes.
might be one approach to look at many of these people, because when you say medication, all kinds of treatment modality is not working, and many times even the so-called allergen-specific immunotherapy is not working. It may just be that the real thing causing their allergy is not being identified. And
Yes.
so I thought that might be an anecdote that might
Yes.
be a little bit helpful to some people who might be suffering silently and not knowing who to help them.
What to see.
And who, even when they have seen some allergies and nothing seems to be working, it might be necessary to say, well, how about food? Let's check if environmental is not, what the
Not a
situation
trigger.
is.
Yes.
So let's see, maybe food or maybe some other things are causing it. Anyway, that's the first one. Then the second one.
This was since 2011.
Right.
It's actually
Many
longer
years.
than 5 years. And Dr. Jagwe used to be on nebulizer 2-3 times a day.
Oh.
It was bad. It was correct when he said his shoulders were up. He was struggling to breathe.
Oh yeah, the best posture for me to be relieved was to kneel down and press my chest against the edge of a chair or the edge of the bed. So that was like my constant position at night when I wanted to sleep. So it was really bad. And so when I feel better, I did not want to go back to that experience. So allergen avoidance, I had no alternative. For me, there was no other alternative. Keep them at arm's length.
You had immunotherapy. He refused it. Like you presented, I drove him to an allergist, and he refused everything that he was offered. He said he was going to do this. The scariest thing is, as Nigerians, especially, we eat tomatoes in everything we cook, in almost everything, maybe not everything, but our sauces are made, out of tomatoes. We will use the canned one, the fresh one, He's allergic to that. He's allergic to everything we eat traditionally.
And
Yes.
the funny
How is he
thing
going to
was,
do it?
he asked me, she said, "Are you sure you're a Nigerian?" So I said, what kind of question is this? Why are you asking me that? She said, because you are allergic to everything Nigerians eat.
Oh my
So anyway,
goodness.
but that is a good report that, right now I can breathe well. I can even do exercise. So before, exercise was a big chore. Now I can walk 3 miles without even gasping, without having any kind of shortness of breath. So that is how well I feel. And I feel there might be other people who can benefit from such, just to check in case it's been overlooked.
Dr. Dapul, that makes sense now. I've always thought of you as German. Now I know you're not a Nigerian.
All right, thank you. You can say that again. Ashtung.
So those were actually some really great points. And there's something that I did forget to mention about the flowering trees. So, we talked about the pollen and what that is. And how it's important in the reproduction of all of the flowering plants. But typically, in general, the ones that have the beautiful flowers, so, our roses and things like that, they aren't the ones that cause the allergy symptoms that we suffer from typically, because the pollen that comes out from these flowering, beautiful, colorful flowers are actually large, they're waxy, and the bees and insects are the ones that pollinate these. So the ones we talked about, which are the trees, grasses, and weed pollen, those are the ones that disseminate through the air and are pollinating in the wind. So those are the ones that cause us symptoms because they're airborne, light, whereas the ones from flowering plants are typically not it, because they are larger, waxy, and are pollinated by the bees and insects. So that's one thing to keep in mind, which, yes, maybe when they're blooming, that's still a problem, but they're not the ones that usually cause the symptoms. And it's interesting that you said when most of your allergy testing was negative, there's a condition I didn't cover because this also could be a whole topic on its own, but it's what we call non-allergic rhinitis or vasomotor rhinitis. And so if your allergy testing, after you do this, whether it's by blood test or by scratch test, is all negative, then what we say there, and how I say this to patients, is, look, you did not make this allergic antibody, right, to pollen, to dust mite, to cat dog. But what you do have is that you are finding things irritating. So imagine, just like you said, oh, there was air freshener, or if during COVID, we're spraying all the stuff, right, to disinfect the rooms. Anything that irritates the lining of your nose can cause the similar symptoms. So I always say to patients, look, if I walked in here with strong perfume, ooh, that might cause you to have a stuffy, runny nose, but you're not allergic to the perfume. It just irritated your nose. And it's important to understand the difference between what triggers your symptoms. Is it just an irritation, or is it really an allergen? Because another thing that can irritate it is if your pollen are negative, that imagine all of that pollen in the air, which again, I showed you that one picture with the tree. Ooh, that can be something that you inhale and will cause symptoms to anybody who's not even allergic. It's irritating the lining of your nose. And then you have the allergy symptoms. So again, there is a difference between allergic rhinitis, which is what we covered today, and this non-allergic or vasomotor rhinitis. But in general, the medicines are still the same, although one medication for nose spray is actually better for the non-allergic or irritant form. And interestingly, your point is that there is a huge connection between allergic rhinitis and asthma. And we didn't cover asthma today because that, needs its whole own discussion. But if we think about it, the nose is connected to the lungs. And this is how I explain it every day, multiple times a day to patients. So when this is inflamed, we get our allergic rhinitis symptoms, but it's the same pipe that goes from the nose down to the lungs. And hence, when the inflammation is in the chest, that's where we have asthma. So again, neck up is allergic rhinitis, neck down inflammation is called asthma. But for many patients, both conditions do come together. And interestingly, if a child has allergic rhinitis, the studies have actually shown that if you do start allergy shots younger, that you can actually prevent the development of asthma. So, right, if we're treating the allergies up here, there's less inflammation, less likely that it goes down into the chest. And what you were saying was very on point, because we see this all the time. There's something called the atopic march. So many people and listeners might be on here where we are starting off with eczema as a baby. And then as you get older, we can potentially develop this allergic rhinitis. And then maybe a couple years later is when you get the asthma. But that is the umbrella conditions of atopy or atopic disease that we discussed, which is why as an allergist, we are very comfortable treating all of this, but not everybody knows that this is what we do, right? So some people might say, oh, I go to a pulmonologist, a lung doctor to see my asthma. I go to an ENT or ear, nose, and throat doctor to take care of my allergies and sinuses. And so I'm trying to help educate everybody and the general public. Oh no, look, if you've got eczema, you've got allergic rhinitis, you may have asthma too. Us as board certified allergist immunologists are happy to help serve you and take care of all of these under one doctor. And not everybody knows that. So me trying to help tell patients and your audience, look, you can go to a board certified allergist and they will take care of all of this and do a phenomenal job, because we really do try to spend the time to hear your history, as you said, right? We're hearing the history, what's going on, and then seeing how your symptoms are, what that diagnosis could be, and then how we can help make a good treatment plan so that you can live your life to the best of its ability outside of our offices.
Thank you so much. You just made excellent, excellent, excellent points, because going to the right specialist for the right entities is key, especially in eczema. Most people will go to dermatologists. You forgot.
Yes.
Then you go to the allergist, and it's very important. When you were talking about, this allergic rhinitis now going into the lungs, asthma actually changes configuration of the lungs if it's allowed to go on like that. So this is very important. And you don't know the episode of asthma that would kill. So Dr. Gina and I had agreed that at another day, sometime in the future, she'll come talk to us about asthma. But we in the spring season is allergy season. We want to catch this early. We don't want you to suffer. Starting this allergy season is why we're doing this now, that we limit it to allergic rhinitis, and asthma is another huge subject that needs to be taken care of. Thanks for bringing
Let me
Dr.
quickly
Jagbe,
finish.
you have your second question. Yes.
Yes. The other question is, do you see a lot more mouth breathing because of upper airway restriction signs and symptoms during this season? And if that is the case, do you try to use buteyko breathing techniques or breathing exercise to help your patients?
So great question about the mouth breathing. I will have to ask you about that exercise because I'm not familiar with it. But yes, so what happens is these nasal turbinates, which are these things that get swollen in your nose, right, will obstruct the nose. And some patients, it gets so swollen where you can't even breathe through it. But for some people, it's not as swollen. You can still breathe. But majority of patients, when they come see us, and probably Dr. O sees this too, one side might be swollen and the other's a little open, then it could switch on a different day. Sometimes they're both blocked. And then when they're both blocked, you really can't get air in through the nose that way, which is why the mouth breathing comes into play. So patients will say, yes, I breathe through my mouth. And, even they sleep this way. So they'll wake up with a dry mouth, dry tongue, and it's very important to address the inflammation in the nose, which is why for some patients, if they're agreeable to it, then I do recommend things like nasal steroids so that we can decrease that inflammation and swelling. And it might not be something you have to take every day, but for example, in the peak of season or when your symptoms are so severe you can't breathe, I try to encourage patients, let's just do it at least for a couple days, get that airway open, and then you can wean off the medicine and not be on it unless you need to be on it again. So the mouth breathing is definitely a thing. What you'll see too with patients who, have a lot of the itching of the nose is what we call an allergic shiner. So there might be some in the audience who have this, but it's a lot of doing this with your nose, and that you'll go to the doctor's office and there's a nice little line or crease right over here. And people won't know that they have that. But the minute you come into a doctor's office or an allergist's office, we're seeing, okay, wow, look at that line right there. And I will ask the patients, I'm saying, oh, do you go like this a lot? And then parents will say, oh yeah, there's a lot of this hand motion. So it's actually called an allergic salute. And then the sign that's there is the allergic, what did we call it? What did I call it? Allergic salute. And oh my goodness.
Allergic salute, and then you have the allergic shiners.
Oh, with the
eye.
eyes.
Yeah,
Yes,
beneath
yes,
the eye.
yes.
It's
Yes.
it's like a dark hue beneath
Yes,
it.
like
Yeah.
little raccoon eyes under
Yes.
here.
Yes.
And that's from all the congestion that's building up in the nose. And we get the allergic shiner under the eye. So I'm sorry, I messed up my two things. So it's allergic shiner under the eye and our allergic salute when we have that crease, what's called transverse nasal crease. There it is. Ooh, right, going across the nose. So these are subtle things that we look for to be able to say to patients and say, look, are you suffering with this? Is this what you're experiencing at home? So that we can do a better job of addressing it individually for that particular patient and helping to take care of it. So, doctor, I'm actually not familiar with that mouth breathing.
Yeah, I'm not familiar with the Buteyko breathing exercise, Dr. Jagwe, either. I've never heard of
Yes.
it.
Well,
Yeah.
I've mentioned it a couple of times when we were talking about sleep.
Is it medicine?
Huh?
Is it medicine? Buteyko?
No. It's a breathing technique,
Okay.
particularly for patients who are mouth breathers.
Okay.
So mouth breathing is not only in relation to allergic rhinitis. Mouth breathing can result from developmental abnormality from the jawbone as well as the nasal passageway, which we see in dentistry. And so when patients have, nasal septum deviation and is blocking their airway on one side, and they have, thickening of the lining on the other side, and so they have almost completely blockage of the upper airway, that is the nasal passage. They are taught to move from mouth breathing to nasal breathing, despite all of these challenges. And it's a form of exercise. And one of the things to do is to switch from hyperventilative phase, which is what happens with mouth breathing, to diaphragmatic breathing, that is using the diaphragm to breathe.
Okay, Dr.
And
Jagbe,
so,
my audience is not following. So
okay, so
when you have, hold it, Dr. Jagbe. What Dr. Jagbe is saying is that, the nose as this, what you call the nasal septum is a partition that is supposed to be straight in the nose so that each nostril have air going in easy. But when there's deviation of that, septum, it's like I can call it, I don't know if I should call it even a bone, no.
Yeah, it's a cartilage with bone.
With bone in it. If it's deviated some, then it would affect breathing. So imagine when it's deviated and the other side is also blocked or swollen, like Dr. Gina had explained earlier, then the person cannot breathe. So Dr. Jagwe says that the Buteyko breathing is when the patient is taught how to breathe through the nose despite all of this. And the way they do that, nose, I'm trying to see who is trying to interrupt the conversation. That the way to breathe through the nose is to use the
Buteyko.
No, the Buteyko, but you said to use the
Diaphragm.
No, not using the diaphragm. The diaphragm is right above the lower ribs.
Okay.
When you touch the lower ribs, there's a film there that partitions the upper chest from the abdomen. That's called the diaphragm. So instead of breathing with that, Dr. Jagwe, you said they breathe which way? They hyperventilate?
Yeah, they hyperventilate because they are breathing through the mouth. And the reason I raised that up is that if they are constantly taking medications and the nasal passage is still restricted, they will become, by default, mouth breathers. And many of these people also have asthma. And so it's a complicated vicious cycle. So Buteco technique was recommended, to help move patients from mouth breathing to nasal breathing. There are several steps of that. The first one is when the nose is blocked,
there's a background noise. Is it coming from you, Dr. Jagbe?
No, it's not coming from me.
I don't see anyone else.
Yeah, you may ask everybody to please mute. So
everybody's muted. Okay. I'm gonna.
Hello, can you hear me?
I'm gonna mute too. Yes, go ahead. We can hear you.
All right. So what normally happens is when people are mouth breathers, they hyperventilate because they have to breathe faster and shallower, which means it's a chest form of breathing when they do that as mouth breathers. So what we're trying to teach them to do from using the Buteco breathing technique is to kind of gradually move them away from mouth breathing. And one of the ways to do that is by taping their mouth closed. So they are forced to breathe through the nose. And you'll be looking at it like, oh my gosh, these people are going to suffocate. No. When there is what is called the air hunger, the nose will open. So you create a air hunger even with a mouth breather without the mouth being taped by pinching the nose. When you breathe in, you try to breathe in as much as you can through the nose, not breathing through the mouth, and then pinching the nose when you hold it for 5 head counts by nodding 5 times and releasing, you will find out that you're able to breathe out. And then you breathe in again, pinching your nose and create another form of air hunger. And then you will breathe because you are increasing the level of carbon dioxide within the lungs, which then opens up and allows you to breathe through the nose. So this is continued until the nasal blockage is released completely. This is not something that is easy for many people who are just trying, but over time it becomes very easy. For those who are habitual mouth breathers who are going through this training, they actually will tape their mouths to sleep because it will have been easy for them to breathe through their mouth when they are sleeping, and they will, because they have defaulted to that. But it's we can talk more about that later on, but it's just something I wanted to raise just in case you use the same technique for some of your patients. Thank you for your presentation.
Thank you. That was why I asked earlier that is it medicine, because Dr. Gina, we didn't learn that yet, right?
No, I have not learned that. That's, something I will definitely have to look up and see if it's something we can use, because not everything has to be a medication, right? And so if there's a technique or, some form of non-pharmacotherapy, I am very open to it so that
that's the reason I raised it up for you.
Yes.
So in case you have been using it, then you can tell us that it's effective. And if you have never used it, then it's something you can look into. But it does. In fact, there are some certifications going on for Buteco breathing techniques. Yes.
Okay, so she would give us update when she comes to talk to us about asthma. We have to remember that.
Yes.
To see what you have found out about it and what we need to do about it. So Dr. Emmanuel Akintono, that's my cousin from Nigeria, actually. They're 5 hours ahead of us.
I saw this is like midnight over there.
Yeah. He said, excellent presentation, though very technical with most technical terms. says his question is, in Africa, they use smearing ointments like rub, bounce, and sometimes they apply warm water. Are these methods appropriate or good enough? He believes that dust is mostly the cause of rhinitis. What is the role of dust to rhinitis, he asked. And he wants to know if those methods are the way to go. And that is true. Let me explain further. People have the sneezing, runny nose, itchy, watery eyes. They take these balms that are really hot. And then they rub it on the nose. In fact, we put it in hot water and cover our heads. I know my friends did that when I was younger, and would, you inhale
this.
the vapor of this
It's
balm.
actually a menthol.
Menthol. I was going to say it sounds like a menthol.
Some say a menthol, yes.
And they would also rub it on the chest, and is asking if this is effective, and is also asking what the role of dust is to rhinitis, because he believes dust is a big cause in Nigeria. And I want to mention also that the research you cited states that there is 22.8% of people suffering from allergic rhinitis in Nigeria. So that is quite significant. Yeah.
Yes. So great question. I'm going to answer the second one first, and then we'll talk about the smearing ointment. So I didn't talk about dust mite because this is a perennial allergen. And so that's, again, the year-round symptoms. So today we are really covering the seasonal, but I'm happy to talk about the dust mite because it's actually my favorite allergen. I get very enthusiastic about this when I tell patients that, oh, you're allergic to dust mites. Let's talk about how this is. And I wonder, because I'm not familiar with what, if the allergen is a predominant one in Nigeria, but how dust mites here are. So they are these microscopic creatures that kind of look like, little spiders, but they're microscopic, so you can't see them. And they cause year-round allergy symptoms here in the United States, as well as abroad. But I mention this because they are a very, very big player of year-round allergy symptoms. And so these dust mites, again, are these creatures. And if you made the allergic antibody to them, that means you're waiting for its partner, and then you breathe in the dust mite. It'll say, there's my partner. It will release chemicals, and then again, you have the nasal and eye and breathing symptoms. So dust mites, as I said, are a common year-round indoor allergen, and they are actually found in your carpets, your pillows, your mattresses, fabric couches, anywhere where you spend time shedding skin. So what they feed on are dead skin cells. So again, you're getting new skin all the time. The old skin falls off. They feed on that. And if you are allergic to these dust mites, then you are sensitive to their feces or poo. So that's why we need to avoid these creatures, because they cause year-round symptoms. And what we recommend for dust mite allergy are things like vacuuming your carpets regularly. So at least once, if not twice a week. If you're able to remove carpet from your bedroom or the house, that's ideal, but some people are not able to do that, so vacuum the carpets regularly. And then one of the big things is to get these things called dust mite covers, which I don't know if they're available in Nigeria, but what they are these little zippers that go around your pillow and they go around your mattress, because you want to lock the dust mites inside where they live. So again, we said they're in your pillows, your mattresses. So if we can zip them up and lock them in there, then that will decrease your exposure to these year-round indoor allergens. And then by decreasing your exposure and you're avoiding them, then your symptoms can get better. So I actually need to do some research and see if dust mites are a known allergen, in Nigeria, because that is huge here in the United States.
Let me tell you right now.
It is
dust everywhere. Roads are not tarred in a lot of places. The dust is incredible. you can wipe now and you will see
Yes.
dust settling
Everywhere.
everywhere.
Yes.
You know,
So
I might just say that that could be just the irritation. You remember you were saying the non-allergen,
allergic
non-allergic
Rhinitis.
irritation.
rhinitis.
Right. So that might be what most people are experiencing in that environment.
No, actually,
Because that's
with dust mites, they would test positive to dust mites. That would be allergic rhinitis. That would be the real thing. The non-allergic rhinitis is when, people are having all the symptoms of allergies. You know it is allergies, but all allergy test is negative.
It's negative.
Environmental and food, the negative. That is non-allergic rhinitis. This one is dust. You're right in Nigeria, we have heavy dust load. Yeah.
Oh, so that's the first part. And the second part, I am not familiar with this treatment, but it sounds like it's very natural and potentially homeopathic. What I recommend to patients is, as long as it's not harmful, then it's something you can consider using. And these things are probably, been passed down from generation to generation, and you can use it and you're like, oh, grandma says we use this and, put our head with the steam. So how I recommend in general, anything, whether it's medicine or whether it's life, is that the benefits of what we do should outweigh the risk, right? So if it's helpful and there's really no side effect to it, why not? But if all of a sudden you're having side effects and there's now things that are more negative than the positive, then it's probably worth finding another alternative. But yes, if it helps and it's something that is used in your culture and community, then as long as it's not causing harm, then why not?
Fantastic. Thank you. Sister Morenike, kindly unmute and ask your question. Kindly unmute. There you go.
Yes.
I can see your
Hello,
face
good
now.
evening.
Good evening.
Good evening.
Yes, I am I practice in Nigeria, but I presently am in the US.
Oh, welcome.
Yes,
ma'am.
and
She's
thank
my
you.
classmate.
Oh, welcome, ma'am.
Small world.
I just want to confirm what Dr. Gina said, that the dust mite is everywhere. I have a personal experience whereby my son used to have this allergy. It was so very much that he had to be on antihistamine virtually every day. And I started wondering what could be happening. Anytime he went to school, he was in the government college. The schools were not the best place, but when he was in school, he would be free of this allergy. No sneezing, nothing, because the bedrooms didn't even have windows. They were always open. So there was good ventilation. But in our house, we had rugs. We had carpets in the house, in the living room, in their bedroom. After about two or three sessions in school, I decided to remove the carpets from their room, from the living room, everywhere. And truly, this allergy virtually disappeared. So definitely, carpets are a very, very rich source of dust mites for the children. I didn't do the allergy test for him because I was scared that, some will take this allergy test and it could be very violent. They could react to it very violently. And I just said, I will make sure that I try to use the rule of the thumb to get to know. And immediately I realized that I made sure that even in his house today, he's about 40 years old. He is good with dust mites. It doesn't be in his house anymore. So I agree with you. And I know that it's everywhere here in the US, in my village in Nigeria. Everywhere. Thank you.
Yes, no, thank you for sharing that story. And it really helps to know that, as a parent, that you realize something is off, and that you put that together where you're saying, well, what is it at home if he's totally fine when he's outside of the house and having these symptoms? And so, yes, as we talked about, removing carpet, if you're able to, can help really decrease these dust mite year-round allergens. And yes, that's a great story. And to say that, you don't need an allergist necessarily to, confirm that the allergy is there, but it's stories like this where, yes, there's something that's a problem in this environment. We are better in environment B. And then how do we figure that out? So a lot of, my work as an allergist is to really be this detective. So patients will come in and say, blah, this is what's happening to me. And whether it's a rash or my eyes, my nose. And so being a good listener is one of the key points of being a great allergist immunologist, because you want to hear what the patient is saying and then be able to put it together to say, well, what is it that's there? If you have a rash, what are you touching in your upper chest that, you're not touching anywhere else that could be causing this? So yes, that's a great, great story about how you can figure out, well, what is it and how can I help my child so that they don't have symptoms? And again, these dust mites are just creatures that, even in the Philippines, they have it, which is where my family is from. And I had visited my grandparents' house in the villages of the Philippines, and their pillows probably were about 50 or 60 years old. So when I slept on it, I really had this huge surge of no symptoms, and I could not breathe. And I actually had to go to another relative's house and say, look, there's something in my grandparents' house that I can't tolerate. And it was the pillows, which again, I can't imagine how many dust mites are in there. So yes, it is probably something where, again, lots of dead skin cells, these dust mites feed on that, and we are sensitive to their feces and excrement. But importantly is to really try to avoid, with the vacuuming, the getting of the dust mite covers and air purifiers, if that's something available to you, so that if they are in the air and, go there, that we're able to get some clean filtered air. But thank you for sharing that story, that wonderful, story about how you as a mom was able to help your son with his symptoms.
Thank you so much. And thank you for bringing up the covers, the allergy covers for pillows. Also, I think they have it for the
The mattress too. Yes.
Yeah,
Yes.
Walmart has them, and they can be lifesavers, So thank you for bringing that up earlier. So Hammond from London said he's enjoying this show as he suffered with hay fever due to grass and tree pollen. You laugh too because with hay fever. He said this could be quite acute in very hot weather. And he found that leaving out dairy products greatly helped him. He uses mometazone furoate, the nasal spray that you've been talking about, only when the pollen season is at its highest for a short period. In recent years, he did not have to use any medication in the summers, but dairy products also reduce a lot of mucus for him when he doesn't take it. He has a follow-up though. He said in his younger days, he suffered greatly from the allergy related to hay fever and dermatitis. For a period of about 5 years, he appeared to outgrow it naturally in early 20s, but he came back with a vengeance by the late 20s. So, comment.
Yes. So it's interesting about the hay fever, as Dr. O and I were laughing, because it's actually a term that's used to describe allergic rhinitis, right? So our medical diagnosis is allergic rhinitis, but many people will say hay fever, but it actually does not involve a fever, which is why, I'm thinking, but hay fever is very, very common to use for this condition. And then in terms of hay, it typically does not involve hay, although if, in the fall time when, farmers are gathering hay, there's this talk that, or this historical data that maybe that has to do with how the name, how it got its name. So hay fever, although again, never really has a fever in terms of these allergy symptoms. So yes, so in terms of appearing to outgrow it, yes, that's definitely possible. Again, why it comes back with a vengeance, years later, it can be if you're in that environment again, right? So if you make these, again, I keep doing this thing with my hands called allergic antibodies. And this is what I do all day long with my patients. So if you made this allergic antibody, whether it's to pollen, to dust mite, to cats or dogs, this is waiting for its partner, right? And then we breathe it in, and then 15, 20 minutes is when we have the symptoms. But if you're not in the environment where this allergic antibody will be triggered, then it's possible that you are not exposing yourself to whatever that allergen is. And so sometimes what happens here with patients is that they will live in California and they'll say, oh, I never had a problem with allergies until I moved to Maryland, as Dr. O had said in the introduction, very commonly. But we say it's because California has a different set of pollen that's out there. Whereas when you move to Maryland, we are essentially a forest. We built houses because over trees and tore these down, but this area is definitely a forest. And because you're now in a different environment, that can cause you to have those symptoms if you are predisposed to having these allergies. Same thing with pets. So you may not have symptoms around, some breeds of cats or dogs. Again, this falls under perennial allergic rhinitis, but there can be some that you do have symptoms with. So again, depending on the environment you're in, you might be exposed to the allergen or you might not. And I've even had patients tell me, can you write me a prescription to live in South Carolina because my allergies don't appear when I'm in that part of the country, whereas it does appear when they're here in Maryland. So again, probably one of the things can be environment if you already had the genetic predisposition, meaning there's somebody in your family who had allergies, you had it for a couple years, and then it went away, and then there's something else that kind of brought it back. So hopefully that addresses, the comment and the question about why it could come back years later.
It says, thanks for the clarification on the terminology for the term hay fever. Appreciated. So yeah, the question is answered. Thank you so much. And I want to thank Dr. Oluyemisi Famuyiwa for introducing Dr. Gina to us. Dr. Gina has now become Medical Monday's family, and that is so awesome. I've been posting and reposting our practice, the Family Center for Allergy and Asthma in Shady Grove Court in Gettysburg. And she'll be moving to Rockville in June, but it doesn't affect us. You can, if you have allergies, you need to see her. They do telemedicine, so you can access her. Just call the office. The phone number is there. Take pictures. Call the office. The phone number is there, and they will work out how you will see her. The skin allergy testing, remember she explained, you get your results in 15 minutes, you know what you're doing. But if she has to order allergy panels by blood, which I prefer, I don't like anybody sticking me. If she has to order that can be ordered and you go do it at the lab and followed by telemedicine. You really don't have to travel to Shady Grove or to Rockville. Those can be done easily. And thank God for telemedicine. Thank God for 2020 COVID. COVID was horrible, but this was one of the good things he has done. So thank you so much. You have been awesome. You broke allergic rhinitis down for us, and non-allergic rhinitis actually, in language that we understand and at the right time. We appreciate you. There's a question. I don't want to miss it before I ask for your parting advice to us. So it says, thank you, Dr. Gina, for an informative presentation. Can you advise how long is the ideal time for you to use pillows and mattresses for?
So yes,
yes.
yes. So especially if you have dust mite allergies, the pillows can last for a couple years, but you may want to consider switching it out sooner than, 3 to 4 years. So maybe every 2 to 3 years, just kind of switching out those pillows. And again, some people don't have problems with the dust mites. So you can have your normal pillow and it doesn't cause you symptoms. So if that's the case, then you can keep it as it is. But if you do have problems with it, then switching it out, but also getting those covers to really zip up those dust mites. What was the other question, Dr. O?
It's the pillows and mattresses. How long is this
yes. So for the mattress, this is really more a personal preference, I think. It's an investment. We spend, was it 33% of our lives sleeping? So you want to make sure that that's comfortable. But if your mattress does cause you to have dust mites, then getting the covers will really help that. So it zips the dust mites in there and you don't have to invest in this mattress very often as much as you do the pillow. And it's because the pillow is where your head is, right? So this is where you're breathing in the dust mites much more often, but the mattress still has the dust mites there. So to answer the question, pillows, anywhere from 2 to 3 years. If you can, invest in it sooner, great. But the mattress, again, there may be people who have it for decades. And as long as you're sleeping well and it's comfortable, then, I guess that's a personal preference more than an allergist saying, oh, you need to get a mattress at year 10, so yes.
Thank you so much. Dr. Booker. Dr. Booker is our anesthesiologist on the floor. So,
and a good friend of Dr. Famiwa. But I learned so much. I didn't think I would. Thank you so much. My daughter had a lot of allergies. Picking her up from kindergarten. No, it's preschool. And but she would say, my face hurts. And these maxillary sinuses, my face hurts. And I didn't know what it was until, in fact, she was diagnosed. It was Dr. Fami's wedding that I couldn't go to help when my daughter was diagnosed with sinusitis. And the babysitter called me and I had to rush her over. So, but I learned so much. When it comes to the bed, I have a cover for my bed. One of the old fitted sheets, I just cover and I wash it from time to time. I didn't buy any cover. And I knew I didn't buy any covers, but I learned so much. Thank you so much. And that thing with covering our head, that's what my father used, using menthol crystal in water whenever there was stuffing. And if you go anywhere, even in England, nobody knows what menthol crystal is. So we're old school. But I learned a whole lot and I will continue to listen. Thank you.
Oh, thank you, Dr. Booker. That's great. I'm glad to hear, you took away some important information and can relate it to your daughter and things. And that's the whole idea, right? It's really educating. And I love speaking about this because little things can really make a huge impact. Right. And, as we speak about these dust mite covers, as small of an investment as that is, I've had patients actually tell me, I got those dust mite covers. My symptoms are better. And symptoms typically are the first thing in the morning when you wake up. Right. That's when patients with dust mite allergy will say, oh, I've got the stuffy, the runny nose, the sneezing. And then as I get up, go about my day, the symptoms get better because you're not in the bed anymore where these dust mites are. So again, some patients have just gotten the covers and not had to start allergy shots. But the idea is, right, knowing that what is the trigger, how to avoid it, and seeing if it applies to you to help your symptoms improve. So thank you. I'm glad to hear your daughter's doing well.
Abby from London says, speaking to us lay people in the language we understand is brilliant. Thank you. And Haman, also still from London, said, thank you, Dr. Gina, for your presentation. Stay blessed. And Sister Esther says, does washing pillows get rid of dust mites?
So yes, they do. Actually, one of the pillows, if you think or suspect you have a dust mite allergy, one of the pillows you want to avoid, and even comforters to avoid, are those that are made out of down. So anything that has feathers, you do want to avoid that because dust mites love feathers. So if you can get any pillow that does not contain feathers, you will be better off. But yes, washing the pillows, hot water will help to decrease those dust mites. And there was something else that I thought about with dust mites. But yes, yeah, something very simple in terms of those dust mite allergies.
Fantastic. So Sister Kia said, thank you. Dr. Ethel said, thank you, Dr. Gina, for a great presentation. And Aman said, mental crystals? I'd like to know more. I am in England, she said. So you have to educate, Haman, about, please chat him up and let him know more about the mental crystals. Dr. Ajagbe, you had your hand raised.
Yeah, but the question I was about to ask about the washing of the pillows.
I see.
Velour or with something that looks like shaggy rugs.
Oh.
And so those are probably more, will be more not user-friendly as regards the dust mite allergy. And I was going to ask about the washing, but somebody already asked. That's why I lowered my hand.
Okay, thank you. Thank you. And yeah, I agree. I think keeping it simple is one of the things I got from Dr. Gina's presentation. I think keeping it simple pillows, the covers from Walmart. I don't I'm sure other stores have it, maybe Target, maybe Giant, I don't know. But I know that, my patients say they get them from Walmart. Just keeping it simple. And yes, you can wash it. I used to think that you can wash those covers, allergy covers, that once you wash them, maybe you wash something off. No, it's not true. You can wash them and then put them back on your pillows and this as well. And again, you have Dr. Gina's information here to ask further questions. It seems that allergies will be bad this year because I'm already patients with allergies already. When we start seeing them early, it's an indication of what would happen. Allergies can be a beast and a behind kicker. Some people will think they have the flu. I've seen that and misdiagnosed as having flu, but they treat them for flu and for all whatnot, and they don't get better. So good history, like Dr. Gina said, how we diagnose. 90% of diagnosis in medicine, history. So please don't suffer starting this season from allergic rhinitis. You have no reason to suffer. We have Dr. Gina in the house. There's no reason to suffer. And I have, you see, when I said you give us your pattern statement, that's when people started asking more questions. So I have one here. Is regular Vicks dangerous for infants? So Vicks, I don't know if you're familiar with it, is menthol also. Those menthol balms that we're talking about. And like I said, people will rub it on the chest, on the nose. I think some people even swallow it. I don't know. And, put it in water and cover our heads on it. So the question is it dangerous for infants to put on them?
So, Dr. O, you may have better experience with this than me, but I don't know what the age limit is on this, although as a mom, I know that I have placed it on the chest when we are congested and having some viral symptoms, but I'm actually not sure what the lower limit of prescribing Vicks is, or the rub, right? Yes.
I will not recommend it personally. I actually don't recommend it. For adults, yes, or from teenage years up, somebody said they have baby Vicks. I don't know, and I personally will not recommend it until I do more research. I can look it up and share it in the future. Hammond says the pollen season has started early in England. So also in the US it has. So Dr. Booker says go to Boots and ask the older folks for a small bottle of menthol crystal, dilute it in hot water and inhale. So Haman, that's for you. Boots is in London. So Boots is a store, a chain of.
Yeah, there's the drugstore in England. Yeah.
in England, maybe generally in England, but I know they're in London. And my sister, this is my biological sister, actually, Abby, she's in London. She says, yes, there are baby Vicks to rub on their chest.
Yes.
She believes in that. She's a lawyer, though. So you can decide to the lawyer over the doctor. I don't know. In this instance, I don't think it matters much. Thanks, Abby. Well, it doesn't seem there are any more questions. And so I'm going to ask that you please give us your parting advice. Oh, no, I'm wrong. Sister Morena, Auntie Ma, you can unmute, Ma.
Please, before you leave, I want to share my observation when we use the menthol crystals. I find that when you put the menthol crystals in hot water and after inhaling, it forms another layer of crystals, either on the water left behind or the bowl when you pour the water away. So my concern is that if one inhales that, does one not have the chance of it being in the airway passage? And that could be, actually, that was the reason why we stopped using it here in the house, because you never know what these crystals can do. They can get into the cells lining the air passage, and I don't know what they can cause. Since it goes into the the steam, it could go into the lungs and stay there. That's my observation. So we have stopped using the menthol crystals.
And thank you so much, Auntie Morena. And she's a physician. So that's why I said, would you want to believe? So Dr. Gina, your question or comment on what she said.
Yes. So I think it goes back to what we discussed earlier, where as long as there's no harm, then it may be still an option. But if there is data and somebody had published something or, reported that there is the possibility of inhaling these things causing some lung conditions, then hopefully somebody would have reported it by now, right? Even in a case report or case series where people who have used this have had some adverse outcomes. But, we all have the choice to decide, is this something we choose to use or do we not? So it's interesting to see if there is any data to suggest that, yes, the crystals that form after you do this, is that also something that can be a problem internally once you inhale it? So because I'm not familiar, I think that would be an interesting thing to look at. But yes, personal decision, right? To say, oh, look, if that's what we're seeing there, then why would we want to breathe it in, right?
Yeah, I never thought of that. And I don't think I ever really paid attention to the crystals in the container when I do it.
You know what? I saw my father doing it for years. And once I finish, he throws it away. You start with another set. You don't use the same container. You just inhale the fumes. And then you wash off that container and use another fresh one another time.
Yeah,
it's just the fumes.
The question is, are there crystals in those fumes? If you see crystals in the bottom of the container that you put it in, are there crystals in the fumes that one is inhaling? It would be a good thing to look at that. I 100% agree with you, Dr. Gina. A lot of these naturopathic things work. They work. We were brought up on them and they worked well.
Yes.
I think a lot of researches need to be done on them, which we should not discard them and see what really works. Our problem as allopathic doctors is we want to see the research. We want to quantity to use. We want to use how often. and what does it react with, and all of that. Without
Yes.
that, we feel uncomfortable because that's our training. The naturopaths take a different path. And I 100% echo what you said. If it doesn't hurt, then it's okay. Yeah. So again, thank you so much. Professor Ogunlesi said, thank you, Dr. Gina, for the helpful presentation. You know, our Medical Mondays family are appreciating you. So at this point, I think we've answered all the questions. I will, yield to you again to give us your parting advices.
Yes. No, so thank you, Dr. O, for inviting me and being a part of your community. This is such an honor to really present and, share my passion about allergic rhinitis and just allergies in general to your audience, to those abroad, those here locally. And yes, I would say that in terms of this condition, it's really important to understand the impact that it can have, right? So as we've all heard throughout the evening, that many of us have had either personal or family members who have had and suffered with these symptoms. And the idea is to really be able to kind of identify, well, what's causing this and how can we manage it so that we can breathe better and that we're not having these itchy, swollen eyes that impact how we live our lives on a daily basis, right? So if little things like closing your windows for a couple of weeks or getting these dust mite covers, for the year-round allergies, if things like that can make a huge impact, then it allows us as, individuals to be able to make our impact on the world, because we need to be able to function, we need to think, we need to study for those kids who are still in school, right? So all of this can really affect us when you are suffering from these allergic rhinitis or hay fever symptoms. So if we're able to address it, identify it, manage it with the great team of doctors and physicians, then you can really be your best self and contribute to the world in the way that you're meant to. So thank you so much, Dr. O, for this opportunity. This is such an honor, and I'm so privileged to have been able to ask to be here and speak to all of you.
Thank you so much. Thank you. We appreciate you. I appreciate you. God bless you. Thank you. And again, the information for Family Center for Allergy and Asthma is in the chat box. Take a picture, save it. Do not suffer starting this season. There's no reason to. She's one of our best allergists around here, and we'll be there to, just make sure that if you're somebody who suffers from allergens, this is the end of it this season. So thank you again. Thank you, everyone. Until we meet next week, please stay safe. COVID still raging. Flu. I was just sharing with Dr. Gina that, it's past March, so there's no flu, but she just shared with me somebody had COVID and the flu together last week, correct?
Yes.